Get ready to listen, learn, and earn CE hours. This podcast features content from an accredited CE activity provided by Calibri Healthcare. Visit elitelearning.com/podcasts for accreditation and disclosure statements and instructions on how you may be able to earn CE credits.
Welcome back to our series, Menopause and the Brain. Last episode, we explored the fundamental neurological changes we see during menopause. And in this episode, we're really going to focus on how we can actually apply a lot of this knowledge in clinical practice. Carrie Levine is back to continue this discussion. She's a nurse midwife and functional medicine practitioner. Welcome back, Carrie.
Thanks, Candace.
So one of the things that you said that really stuck with me in episode 1 was when we were talking about how menopause really is such a significant milestone in life for us, kind of that hallmark point in our life. And honestly, this is really something that I say almost everyone who is born with a womb is going to experience, because I feel like there's always an exception. You just never know what that exception is going to be. But it really marks the end of your reproductive years. So I could see some grieving that would come into play as we enter this transition as well.
For sure. I mean, women respond in the whole range of ways to this time. Some women, it is deeply, deeply sad. For other women, they're like, hallelujah, why did it take so long? And I think that, for most of us, our monthly cycle is like a North Star, right? It's like we can have this whole range of physical and emotional experiences that we're like, what is going on? And then we get our period and we're like, oh, now that all makes sense. Of course, I got my period and now everything feels different again. And without that, that punctuation, it can feel really disorienting to not be cycling in the same way. Although I will say that many women still cycle even in the absence of having a period. If they're paying attention, they still feel all the things. They feel sexual, they feel fatigued, they feel super energetic or super fatigued, or wanting good food or not good food, or digestion is this way or that way. Many women will say they can still feel themselves cycle through the course of the month, even if they're bleeding. It's pretty cool.
That is interesting.
Yeah.
Well, what I also find so interesting about menopause and perimenopause and postmenopause is that it really just kind of seems to remain a mystery, with the stigmas and those misconceptions attached to it, not just for, us as women, but also for providers.
Yeah.
And, I saw a study here recently that stated about 2/3 of healthcare providers feel undertrained in managing menopause symptoms.
Yeah.
But 60 to 80% of women will seek medical advice for these concerns, but nearly 3/4 of them are left untreated, undertreated, or mistreated. And I don't mean treated terribly. I mean, just they're not treating it correctly. And why do you think that there's such a gap in that understanding and in that confidence in treating it?
I think there's quite a bit of data that is revealing that there's a real absence in medical education around taking care of postmenopausal women. Physicians and practitioners are just not trained. And hopefully that's changing. But I am still blown away. I am still so blown away by the number of women who show up on my doorstep, who tried to have a conversation with their primary care or even OBGYN. And either, to your point, to your statistical point, right? Either the practitioner tried, but didn't really know what they were doing.
Right.
Didn't really know the risks or benefits or what was needed or what testing to do or is valuable or what are the parameters or what are the they just don't know. And women will come and say over and over and over again, I just cannot believe the extent to which people are not talking about this. Either
Yes.
my experience or how to take care of it, like what support to
Hmm.
offer. And I'm like, really? Well, I don't know what your logarithm is doing because everybody in my feed is talking about it. So
Yes.
there is information out there, but still women seem to be having quite a challenging time accessing it, which does it surprises me.
So, in the previous episode, you really hit on a lot of those common symptoms, the effects on the brain from the hormone fluctuations. And can you start with helping maybe to talk about the appropriate lifestyle modifications that we should be making to really help support our brain health during menopause? And, also when I think about this, not just brain, but I also think about my bones as well.
Yeah, for sure. There's a OBGYN named Joel Evans, who teaches for the Institute for Functional Medicine. And when he teaches the hormone module, he says, or at least he used to, and maybe it's changed, but he says adrenals, 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 adrenals first. So adrenals, for listeners who don't know, are small glands that sit on top of the kidneys, and they are primarily responsible for cortisol production, which is our stress
Yes.
hormone. Secondary is epinephrine and norepinephrine, and then they also make some DHEA, which, when you look at the cascade of hormone production, is the biochemical precursor to testosterone, which is also the biochemical precursor to estrogen. And so
Mm.
there is this physiologic phenomenon when there is chronic and sustained stress that pregnenolone will get preferentially shifted to DHEA, the stress hormone. And then it's got to go through all of these pathways to get down to the sex hormone. And whereas when there's less stress, that pregnenolone converts to progesterone and there's overall better hormone balance. So stress is the first place to start. And that is part of why I think midlife is as turbulent as it is, particularly for
Hmm.
women in this country, is that there is that perfect storm.
Hmm.
We've been raising careers or raising families. We historically have not taken care of ourselves optimally in an effort to be successful. And the body, kind of with the shift in ovarian function of
Hmm.
estrogen and progesterone, there is not the kind of resiliency that there was when we were 30. And so we have to modulate stress. That is first and foremost. And it is the hardest, right? Like,
Yes.
it's so much easier to say, oh, pop this supplement than it is to
Hmm.
change your life. So, that takes a lot of courage, and it also takes a helping hand. And whether that's with a practitioner or it's with a therapist or it's with a coach or it's with a accountability buddy
Yes.
or a friend, that is huge, absolutely huge. And I like to say to women, I've never met a stressed out woman who felt well and had hormone balance, like super stressed.
Yes.
Like super stressed
Yes.
and not taking care of herself. We can handle stress.
Mhm.
We just have to leverage it with
Mhm.
self-care, which is a term I really don't love, but I think people know what I mean when I say it, right? With rest
Mhm.
and recovery and restoration and nutrient-dense food and movement and time in the natural world and sleep and care and fun and laughing. It's like you can work hard, but you got to play hard too. And not
Yes.
not many of us do that.
We're very good at working hard. We're not very good at playing hard.
Not as
Uh,
good, not in this
no.
country. Yeah.
And it's so interesting that you're talking the first thing you're talking about is stress because when you think about stress, you think about the cortisol, but you also think about all these other negative effects like insulin resistance, weight gain. But now you're talking about stress in the view of we're losing these other hormones, these protective hormones. So now we're seeing more stress. So now you're getting more of that inflammatory response. And so just hearing how all of these interconnect is it's a lot to take in, but to understand if we could just take some time to recover, restore, have
Yeah.
fun, it
Yeah.
would help to lower all of that.
That's exactly it, right? And that's the beauty of
Mhm.
functional medicine and systems biology, right? For me, the metaphor that I love is that of the spider web, right? Everything's connected to everything. All
Mhm.
you got to do is pull on one strand, and the shape of the web changes. You can't do it all at once. And in some ways,
Yeah.
you kind of want to pull on one strand and see what happens. The
Yes.
stress is huge. From there, there's food and nutrition,
Hmm.
right? And so
Hmm.
they're really, there's quite a bit of data that is um, revealing that what works much better for postmenopausal women is high protein. And that protein count is so much higher than it was back when I first started practicing in this way. So the current conversation is somewhere between 30 to 50 grams of protein 3 times a day,
Oh, wow.
which is a
That's
lot.
a lot.
And what I encourage people to do is not weigh and measure their food because I don't think that's a sustainable practice at all. But to
Hmm.
Google 30 grams of protein and look at some pictures of what that looks like and
Hmm.
then just shoot for that. It's not even like you have to hit it. You just want to
Hmm.
have that awareness.
Hmm.
So lots of protein and lots of vegetables. And the vegetables are crucial because they support liver function, which supports hormone detoxification and can prevent the metabolism into 4-hydroxyestrone, which has been shown to cause DNA damage and be an indicator for an increased risk for breast cancer. That can be modulated. That metabolism can be modulated using things like large amounts of cruciferous vegetables, the broccoli, the kale, the collard, the Brussels, those kinds of
Things
vegetables.
that look like brains. Is that what you're saying?
In France, they eat brains. I just
No,
watched a movie about this and I was like,
I did
wow,
not.
okay. I digress. But
What is that word in French? So I make sure I don't eat that.
I know. Huge amounts of vegetables, huge,
Mhm.
huge, huge, huge for all the reasons, right? The liver detoxification support that helps regulate hormone balance. It's real. That are
Mhm.
high in fiber, which fuel the gut microbiome, which helps keep our immune system healthy, right? And here's where again it kind of like it all comes together.
Yeah.
And so the vegetable part is huge. And then the other thing that women will note is just a carbohydrate intolerance, right? Like we can't eat carbs the way we used to, the bread, the cereal, the pasta, or even the
Mhm.
alcohol, the wine, which is pure carbohydrate. And part of that is in part because of what you spoke to, right? Which is high cortisol, high
Yeah.
insulin, right? That also contributes to belly fat. By the way, it's not just the sex
Mhm.
hormone imbalance, it is
Mhm.
the hypercortisolemia and the hyperinsulinemia that leads to the insulin resistance. And estrogen also, less estrogen contributes to insulin resistance. So it's like a double whammy. And
Mhm.
so the amount of carbohydrates that we need is really much less than when we were younger, depending on your lifestyle. If you are an elite athlete and you are, or you work outside and you live an incredibly active lifestyle, that's different than most of us who are sitting behind a desk, behind a computer for the better part of every day. And so it's not no carbohydrates, but it is less carbohydrate and also focusing more on the complex carbs. And I like to tell women the easiest and the hardest place to slash and burn carbs is by reducing wine intake. And if you're not sleeping, that's also the easiest place to start. Easy,
Yes.
easy on the one hand, and the last thing that women want to eliminate on the other hand. So,
Right. Yes, because they're
e-
already in so much chaos that they're like, "Oh, if I could
yeah,
have this one glass of wine." But as something else that really stood out to me when you were talking about physical activity, but you're also talking about those stress and the high cortisol and not having that estrogen. But some exercises I learned through functional medicine is that I couldn't figure out, why can't you lose weight when you're going through all these changes and all this chaos and stress? But it's because some of the exercises also continue to raise your stress,
mm,
raise your cortisol. And so then you have the opposite effect of what
right,
you were trying
right,
to do
right. Which is
through
why you have to be
exercise.
careful. Right. Which is why you have to be careful. And women we still have this calorie in, calorie out equation in our head. And there is an aspect of that that is real, but it is much more complex than that. Because let's be honest, if that worked, there would not be a bazillion dollar weight loss industry because women would do
Right.
it. they
Mhm.
would do it because that's how desperate they are, because the lengths that they go to lose weight, if it were simple calorie in, calorie out, it would be done. So it's true. And that this also dovetails into the conversation around intermittent fasting, right? We could talk for hours, right? About
Right, yes.
what about intermittent fasting and postmenopausal women and women who work out in the morning? I just want to recap something we said in the first episode, and just to make sure it gets said on this episode, that the general recommendation for movement for a postmenopausal woman is 2 30-minute strength training sessions a week and 3 to 5 interval training. So speed interval or high interval training. That zone 2, that long walk in the woods with the dog that brings people joy, or the super moderate whatever, is not going to get done what needs to get done, what used to get done when we had estrogen on board.
Mhm.
The strength training and the interval training is the estrogen replacement for muscle mass retention, body composition changes, et cetera. So just want to make sure to recap that. And I've lost track of what your question was, if there was a question.
Oh, no, well, we were talking about high intensity versus high cortisol versus high stress.
Right, 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 right. I mean, and
Mhm.
that's the thing, right? Is tired women will drive themselves and be like, I'm so exhausted, but I'm fat and I want to lose weight. I'm gonna go work out. And then they're flatlined for 4 hours afterward. And so if
Mhm.
that's what somebody's doing, what I tell them is like, if you work out and you need to take a nap for 4 hours, it was too much. Sometimes women need to really give themselves a period of rest and restoration and back off from the exercise so the adrenals can recover, so that they can then withstand an intense training session,
Right.
um, and not have it be compounding high cortisol.
Yes, and that is hard to understand how,
Mhm.
you're like, "I'm doing all the things. Why is this not working?"
Yeah.
And this is why. It's because 'cause you're playing your hormones, your cortisol against itself. Um,
Yeah.
well, I wanna also go back to talking about some of those mood disorders you kinda mentioned in the episode 1, depression, anxiety, and, how is the best way for healthcare professionals to really address those mood disorders that are really associated with the chaos that's happening with what's happening in their body through this time?
Mm, um, that one's a little bit tricky for me to answer because, I've taken care of women my entire career. And
Mhm.
when I first started at Women to Women back in 2006, every other woman was walking in with a diagnosis of bipolar.
Oh.
And really what she was experiencing was a cyclic mood change that was
Mhm.
related to her hormones. And so depression and anxiety, the frequency with which women are diagnosed is of concern to me. Um, which isn't to say I don't think it's real. I do, but I think that the conversation around it is often more complicated than what can happen within the context
Mhm.
of a routine visit. And too
Mhm.
often women are given a prescription without having the opportunity to talk about, well, are you sleeping at night? Because if you're
Mhm.
not sleeping, your mood probably isn't going to be great. And what
Mhm.
is the stress in your life like right now? How much caretaking are you doing? How is your relationship at home? Are you caretaking for your parents? How full is your plate? Right. And there are some real things that lead to women feeling anxious, in which
Mhm.
anxious would be an appropriate response to a circumstance as opposed to a certain pathology. Are there
Yeah.
women for whom their mood defies reason? Of course. Of course. But for me, depression and anxiety always, like, I'm always working the functional medicine matrix. I'm always thinking about why. Like,
Mhm.
why? Why is someone feeling this way? And what were the antecedents, triggers, and mediators? Like, s- people weren't born that way for the most part. What
Right.
happened? What happened? And when you have the opportunity to spend time with women probably people in general, I just take care of
Mhm.
women. Women will say almost verbatim, I haven't been the same since dot, dot, dot. And they'll fill in the blank. And that could be in relation to their mood. That could be in relation to their digestion. That could be in relation to whatever it is that has brought them in through the door. I haven't been the same since. So I
Mhm.
think my first recommendation to clinicians taking care of women would be to ask why. Why is this woman depressed and anxious? Are there really easy variables? Easy,
Right.
variables that can
Yeah.
be modified, right? Like, how much processed food is she eating? How much
Mhm.
sugar? How about artificial sweeteners? How much alcohol is she consuming, right? These are foundation questions related to mood. If a gut is imbalanced, then neurotransmitter production is not optimal. Depending on who you read, 70 to 90% of neurotransmitters, serotonin being the primary antidepressant neurotransmitter, and GABA being the primary anti anxiety neurotransmitter, are made in the gut.
Mhm.
If we don't have a well balanced gut, we are predisposed to a mood disorder. So, is it depression or is it a messed up gut that needs to be addressed? Do we need to pull out those inflammatory foods and rebalance the gut microbiome so she optimally makes serotonin, GABA, and lo and behold, her depression is resolved?
Mhm.
So I'm complicating the question because obviously the topic for this conversation is around
Yeah.
hormones and mood. And I will say that in general, low progesterone is what occurs premenstrually and
Mhm.
immediately postpartum. So postpartum depression from a functional medicine perspective is a progesterone issue, and that gets treated with progesterone, not necessarily an SSRI kind of thing. And so like all the sleep disruption hugely related to progesterone deficiency or fluctuations,
Mhm.
um, the mood stuff, whatever that is for a woman premenstrually, immediately postpartum, and during perimenopause when ovulation is irregular, right?
Mhm.
Progesterone primarily being produced by the corpus luteum, that is the remnant from ovulation. And so if we don't ovulate, there's no progesterone. Well, that doesn't feel very good for many people.
Right.
And then the estrogen deficiency in terms of mood, generally, I would say in my clinical practice presents as anxiety, like an anxiousness that is unfamiliar to women. I will see women who say, I've never been anxious in my entire life, and I am anxious now, or women develop panic disorders
Mhm.
as a result of low estrogen. So I see both hormones having the potential for supporting mood during the postmenopause time for sure.
So, talking about, replacing hormones, can you talk about the benefits and risks of hormone replacement therapy for brain health?
Yeah, there was a big shift that happened last year with a revamping of the Women's Health Initiative findings.
Mhm.
And so today, the current thinking is that the risks are primarily associated with uterine cancer and blood clot development, which can lead to stroke. The risk associated with breast cancer was rescinded last year. So that's a big deal. There's a lot of women and a lot of practitioners still coming out thinking hormone therapy is associated with an increased risk for breast cancer, and that was rescinded last year. Benefits of hormone therapy are thought to be to the brain, the bone, the heart. Genital urinary symptoms of menopause. This is a big one. GUM didn't used to have a name. The menopausal woman who is sure she has a UTI, whose practitioner never actually makes her go in and do a urinalysis and gets treated
Mhm.
over the phone over and over and over again, only to find that it doesn't actually work because it's actually a low estrogen issue. Any mucous membrane in the body is going to be affected by estrogen. That's going to include the eyes, the mouth, the nose, and the vagina, not to mention the lining of the urethra, not to mention the anatomy of the top wall of the vagina being juxtaposed to the urethra. And so, with low estrogen, that burning sensation can persist. So, hormone therapy, well indicated for that. And then the less research valid findings of benefits to hair, skin, nail, mood,
Right.
joie de
Mm-hmm.
vivre, right? Many, many women will experience an apathy of like, I don't even care. I don't even know what I want to do. I don't even know what I like anymore. And part of that, I think, is that brain chemistry shifting and changing from like having to be in overdrive all the time, managing work or family or home or whatever it is. And like that intensity isn't necessarily needed anymore. And the brain's like, I don't really know what to do with myself. So while that systems upgrade is happening, there can be that period of time that feels a little bit like a free fall.
That's a lot to think about in deciding should I go the hormone replacement therapy route or should I forego
Yeah.
the hormone replacement therapy route? And if you have someone that's kind of on the fence and struggling, what would if you have a practitioner who has a patient that is kind of sitting on the fence struggling, what would you say to them to help them determine, is this the right direction or is it not the right direction?
Well, I am about empowering women. And so for me,
Hmm.
it's about patient choice. Does she want to try it? Is she curious? Is she interested? In
Hmm.
her own math, do the potential benefits outweigh the potential risks? And does it feel worth it to her? I have a lot of women who are like, with all the buzz around hormone therapy, they're like, I'm just kind of curious. I mean, I get that question a lot like, is hormone therapy right for me? And
Yes.
my answer is, unless there's something glaring in the personal health history or the family health history, I'm like, I don't have the answer to that for you. I really have no idea what is going to happen when that tiny molecule hits your bloodstream.
Hmm.
And if you're going to feel amazing and you're going to sleep like a baby and you're going to think clearly and feel energetic and be like, where has this been for the last 20 years?
Hmm.
Or if you're going to feel terrified that you're going to get uterine cancer every day and that you're going to develop a blood clot like your best friend or your best friend's sister, or do you
Hmm.
know what I mean? We as
Hmm.
women bring so much to the table in terms of our decision making. So for me, it's really about meeting the woman where she is and trying to understand where she's coming from in her curiosity, and then helping guide her toward, at the very least, a safe choice.
Hmm.
Yeah.
Absolutely. And when we're trying to make that decision and you're trying to guide your patient, what resources and support systems do we have available to help make that decision?
Mm. I generally refer people to a book by Avram Bloomberg called Estrogen Matters.
Hmm.
I certainly send people to Mary Claire Haver's book, The New Menopause, but I have some concern about all of it. I
Hmm.
am now sending people to The Menopause Brain by Lisa Mosconi. I think she actually does a really good job at proing and conning hormone therapy and addressing all the other parts and addressing herbs and supplements. She actually has a lovely section on herbs and supplements that have hormonal um, aspects to them. And she looks at the research and she sort of rates it. So I'm using that book now. Where else do I send people? I will send people to the North American Menopause Society website, but I do not, you know, research can be presented
Hmm.
with whatever bias somebody wants it to have.
Right. Yes.
So, it's a little bit tricky, and it has been really helpful for me to be reminded that these professional organizations have recommendations, and
Hmm.
they are recommendations. And
Yes.
I feel like it's easy to get scared as a practitioner of like doing the wrong thing or making a
Hmm.
mistake or,
Hmm.
um, and of course, none of us want to harm anybody. But I feel like that's where you really want your patient as partner so that
Hmm.
she's weighing into the decision making and you do the best you can and you document well. And, for all the concern that happened with the Women's Health Initiative findings and the pulling back of the hormone therapy, knock on wood, I have been prescribing hormone therapy since 2006. And I'm so grateful, so deeply grateful for the way that I was trained, which was bioidentical only through the skin, except for progesterone when there's a sleep issue. It used to be the lowest dose necessary for the therapeutic goal. That has changed. It used to be 10 years, then it was 5 years. Now there's no limits. And it's one woman at a time. Her personal concerns, her personal health history, her family health history. I have had one woman have uterine cancer since 2006. Now I have a very small practice. I'm not like trying to
Mm-hmm.
misrepresent myself.
Right.
And and the women that I see are generally well. They're,
Mm-hmm.
they are not generally, they don't hit the other demographic characteristics for risks, right? They're generally not tobacco users. They're generally not, these are women who are generally speaking educated, active participants in their health. And so my population is inherently biased. And I have had one woman have uterine cancer in 19 years of prescribing hormone therapy. I tell women, do you carry a cell phone? I have more
Yeah.
concerns about the risk of carrying a cell phone or like sticking it in your bra and the incidences of breast
Mm-hmm.
cancer and
Mm-hmm.
sticking your cell phone in your bra than I do around hormone therapy. When it is prescribed in relationship with an individual woman, right? And I feel like that's a big part of how I get to practice that's different than
Mm-hmm.
many conventional practitioners, right? Which is just like, we are in a relationship. I want to hear from you. This is not goodbye and good luck. If something doesn't feel good, if you've got a low grade headache and breast tenderness and it's not abating, I want to hear from you. If you're
Yes.
bleeding, I want to hear from you. And let's talk it through and let's troubleshoot. And if you need an ultrasound, let's order an ultrasound. And if you need a biopsy, let's do a biopsy. And if you need a consult with a GYN, let's do that. And if
Mm-hmm.
you're afraid of your heart and your heart palpitations, which is one of the biggest presenting clinical symptoms of perimenopause. If you're afraid you're having a heart attack, let's get a cardiac evaluation and make sure that your heart is well. And then
Yes.
let's talk about hormone therapy, right? So, like, really mobilizing a team and not feeling like I have to or can do it all. I cannot. I am not a surgeon. I am not a cardiologist. I am not an
Mm-hmm.
endocrinologist, although I do a lot with thyroid. And I mean, and you
Yes.
can't even in the state of Maine, you can't even get in to see an endocrinologist right now
I think
unless
that
you
is
have a tumor.
United States wide.
It's incredible. I'm getting
Yes.
7-page faxes from the endocrinology office saying, here's how to manage your typical hypothyroid. I'm like, okay.
Yes.
But like, what is the endocrinologist going to do really other than adjust meds, which like
Mm-hmm.
I can do that. And I can also talk about the HPATG access and solicit and elicit participation in someone's care so that it's not just about the medicine.
Yes. So much great information that you have covered today. As we conclude today's episode, I really just kind of want to take a minute to really reflect on why this matters and why we should be aware of menopause and how it affects women and how it affects their brains and what those symptoms are. And you mentioned heart palpitations, and I just had a 7-day Holter monitor because I was like, I'm pretty sure it's anxiety. And they didn't find anything. But I'm like, but that's and so it's just kind of affirming,
Yeah.
um,
So where were
what is
you with your
happening.
cycle, Candace? Just
Yeah,
kidding.
I know, right? Nobody asked me. Nobody asked me where I was in my cycle. Oh, I'll have to call them when we get done here. But women spend up to about 40% of their lives in this postmenopausal period.
Mm,
And in the US, I saw the average age for menopause for women is about 51.
mhm.
So, historically, though, menopause related cognitive and mood changes and all these other symptoms like heart palpitations, apparently, they're undertreated and often dismissed. The numbers really tell us this compelling story because while I did see numbers all over the board, what I did see was that they were on the higher side
Mm.
of the numbers. Yeah, I saw a survey the other day that said this was done in 2021 that said 73% of women don't receive treatment for their perimenopausal symptoms. And the reasons were identified as lack of education of healthcare providers. So they didn't know what to do, dismissal of the symptoms, and of course, that stigma and that their own perception that we talked about earlier of even validating, why should I seek treatment for this?
Mm.
So, but what I found really sad, besides the 73% of women who are not receiving treatment, was that 90% of these same women that were surveyed said that their symptoms interfered with their daily lives.
Mm.
So
Mm.
when we consider that women who are moving into perimenopause and into menopause, they're dealing with these symptoms. They're often at the peak of their careers,
Mm.
caring for children and aging parents, making major life decisions, supporting their cognitive and emotional health is going to be so absolutely crucial. You hit on all of those things that I just stated of where we typically are in life and why it is so hard to rest during this time. So I really think it's important for us to understand these neurological impacts that we see with, I want to say perimenopause now, because, really we're seeing these symptoms in perimenopause moving into menopause. And it allows us to really validate our patients' experiences to provide the appropriate evidence-based treatment, which is going to help to maintain their quality of life during this transition. Because if it is affecting their life, it's affecting the quality of their life. So
Mm.
it's not just about managing the symptoms, but as you said earlier, it's about empowering women to thrive during this significant life stage. So, Carrie, is there anything you want to add or, want our listeners to remember as we close this podcast series?
I think I just want to reiterate, that as practitioners, if people are listening, are practitioners, that there are some really positive things that happen for women later in life, and that we want to talk about those things, right? That it's not that menopause or postmenopause is not like, be quiet and go home time of life. Like women do amazing things during this time of life. And there is tremendous potential, tremendous personal potential, creative potential, professional potential, and that we can live that. Some of us just need some support and some belief in that possibility along the way.
Yes, absolutely. Well, thank you so much, Carrie, for being a part of this conversation and just bringing your wisdom and your support and your knowledge to our listeners today.
Thanks for having me. It's fun.
Yes, to our listeners, thank you for taking time to listen to this discussion. And if you found this information valuable, please share it with your colleagues. And I also encourage you to explore many of the courses that we have available on elitelearning.com to help you continue to grow in your careers and earn CEs.
This podcast featured content from an accredited CE activity provided by Calibri Healthcare. Visit elitelearning.com/podcasts for accreditation and disclosure statements and instructions on how you may be able to earn CE credits. Take your learning to the next level by subscribing to more podcasts on compelling healthcare topics.